Presenters for this afternoon are myself, Joe Tissier, and then there's Lewis Rivas and Tracy Gibbons. This webinar will be recorded, so we've muted you and ask you also to turn off your cameras. The slides will be sent to attendees and the recording of the webinar will be uploaded to the CEG website, so you can have a look at it again in a few days' time when it's been published. Okay, the agenda. What's this webinar going to cover? We're going to do changes to the QOF for 2024 to 25. This is not a presentation that's going to go through all the QOF indicators. It's rather focusing on the changes, and we'll also spotlight some of the indicators in QOF that sometimes cause practices problems. We're going to cover the PCN DES, IIF. Again, we can't cover all of the DES, but we're going to cover and spotlight the areas that CEG can support you with. We're going to cover the NEL Data Accreditation and Improvement Incentive Scheme, and most importantly, we're going to cover all the ways that CEG can support you with the contracts. All areas will have had their webinars on local enhanced services, so we are not covering that today. If you didn't manage to attend the locality workshops, the recordings are available on our website and we'll give you details at the end of the presentation. Firstly, this slide is just here really to give you the hyperlink. There's also a QR code that goes to the NHS England website. And on this website, you'll find all the publications for QOF, seasonal flu, PCN DES, weight management, etc. And I'd urge you to have a look at these documents. As I said, we can't go into huge detail, but you'll find much greater detail if you look at these documents. Okay, let's remind ourselves of QOF. So first of all, QOF has total points of 635. The point value has gone up this year to 220.62, so a bit of an uplift from last year. Clinical indicators, there's 401 clinical indicators. Quality improvement, there's 74. And for public health, there's 160 points. Sorry, there's not 401 clinical indicators, that's points. Okay, last year in QOF, 19 indicators were income protected. This year, 32 indicators are income protected. That's an additional 13. So out of the 635 points, 212 points have been income protected. That's a third of the total points available in QOF. So what areas are income protected? There's 19 disease registers, 81 points, 7 disease indicators, 57 points, and the 6 QI, quality improvement indicators, that's 74 points. What does income protection mean? Well, for the indicators that have been income protected, the 24 to 25 achievement in points will match your 23 to 24 achievement. So we're all hoping you did well in 23 to 24. Practices will not be penalised for failing performance within the income protected indicators this year, but also you won't be rewarded for improvements. Remember, this is really important, that QOF earnings are subject to prevalence adjustments, list size variations, which will be based on 24 to 25 figures. Therefore, what this means is it's important to maintain your disease registers, even if they're income protected, as the failure to maintain registers will impact the prevalence adjustments that are put on your achievement and therefore will affect your practice income at year end. What we've done to help you with this is that we're currently updating our CEG prevalence improvement searches, which are soon to be published, and then you can use these to identify people who might need to go on those disease registers. So the income protected, there's 19 registers that are income protected. As I said, that's 81 points. The registers are on the slide there. I'm not going to read through them all. It's most of them. And as you can also see in there, the obesity register, which is part of the public health domain, has also been income protected. Which disease indicators are income protected? Well, there's 7 disease indicators which add up to 57 points. Hopefully, as I said at the beginning, practices have performed well on these indicators last year. So the ones that have been income protected, there's one in the asthma domain, the aged 19 and under with smoking status, the 2 cancer indicators, there's one in the COPD clinical domain, pulmonary rehab referral, now income protected, the depression review, income protected. In the mental health domain, you may remember that there was an indicator for all the 6 physical health check elements having been done. That is now income protected. And for the public health domain, the indication that is smokers with chronic disease that offered support to quit is income protected. You need to be careful, however, with stopping doing things just because they've been income protected. One, because next year, if the same indicators are not income protected, some of those, for example, the depression, looks back to the January of the previous year to see if the indicator was done. And if it wasn't done, then that will be included as part of the achievement for the next year. Also, some of these indicators, the one I can think of here is the 6 physical health check elements for mental health, may well be covered in your local enhanced services. So you don't really want to take your eye off the ball on doing this. And also, if you read the guidance in those documents that are highlighted in the 2nd or 3rd slide from NHS England, the guidance is very clear that they expect you to maintain the registers and also to continue the work. So there have been some changes for QOF this year. So this is looking at the cholesterol domain. So cholesterol 001 has now been replaced by cholesterol 003. I'll just read it. The percentage of patients on the CHD, PAD, stroke or CKD register who are currently prescribed a statin or where a statin is declined or clinically unsuitable, another lipid-lowering therapy. Now that does look exactly the same as cholesterol 001, but the changes are to do with the exclusions or the PCAs. You'll probably be pleased that actually now patients who have had a hemorrhagic stroke are now excluded from the denominator. That's a new exclusion. Another new exclusion that I suspect you'll be pleased about is that non-responders to 2 cholesterol monitoring invitations, at least 7 days apart, are also excluded. Just one other point to raise on this, and the point is that you can also exception report. If you've got somebody, for example, who declines a statin and they decline all the other lipid-lowering therapy drugs from all 6 groups, instead of saying you've declined a statin and declined all 6, you can use the overarching lipid-lowering therapy declined code, and that will remove that patient from the denominator. The next indicator, in this one, cholesterol 004 replaces cholesterol 002. And what's happened with this indicator is that the cholesterol measures have swapped around. So now the indicator is looking at percentage of patients with CHD, PAD or stroke. Note that CKD is not included in this. With LDL cholesterol less than or equal to 2, or where LDL cholesterol has not been recorded, non-HDL cholesterol is less than or equal to 2.6. And again, as you can see, the target, the 2.6, is higher than it was in cholesterol 002, and LDL is now 2 rather than 1.8. So again, you'll probably be pleased with that. Just something to note really is just check your lab results just to ensure that the coding, you are getting LDL and non-HDL cholesterol coming back via the links, via your labs. There are some personalised care adjustments or exception reporting for cholesterol 004. There's maximum tolerated lipid lowering therapy. That's for cholesterol 004 and actually the other cholesterol indicator too. Again, new PCAs, lipid lowering therapy not indicated. Cholesterol test decline, that was there last year. Lipid lowering therapy decline, that's a new one. The two coded cholesterol invitations, so that's good because it's for this one and the earlier cholesterol indicator. Then you've got the earliest diagnosis of CHD pad stroke from July 24 onwards. That's new, so if the patient has a new diagnosis from that time frame, they'll be excluded from the denominators. Patients with a hemorrhagic stroke also excluded, and people registered in the last 3 months, but that was there last year as well. Okay, there's been a slight change for the QOF blood pressure indicators. As you can see, there's numerous blood pressure indicators for the different clinical domains, whether it's CHD, diabetes, hypertension, stroke. And the change is that the ambulatory BP targets are now set the same as the home BP reading targets. So for example, in CHD 015, patients aged less than or equal to 79 with CHD, latest BP in last 12 months, less than or equal to 140/90, or equivalent home BP reading, which would be 135/85, and that would be the same for ambulatory BP as well. You do have here some exception reporting, PCAs. If you record that a BP procedure has been declined, or home BP monitoring declined, or ambulatory BP recording declined, that's new for this year, then that will act as an exception. On our LTC template for both System 1 and EMIS, we do have the ambulatory blood pressure codes on that template, and we do of course have all the PCAs, the exception reporting. Okay, we've looked at the changes, and I thought what we'd do now is do a little bit of a spotlight on some of the other indicators that sometimes practices ask us about, and they seem to cause problems for practices. And also there's a couple of domains in here where there's new guidance in the documents, and I just want to highlight that for you as well. So with the QOF asthma domain, 1, 2, 3, 4 indicators, but the asthma register now income protected. Asthma 011 is to do with the diagnosis of asthma and to do with needing spirometry and other objective tests. The thing I want to flag up here, I mean this is the same as last year, but what I want to flag up here is that if you've got a spirometry service that's not available, well, you haven't got a spirometry service, you can use that code, and again that works as a PCA. Asthma 007 often causes problems, and that's to do with the kind of time frame of all of this. So what they're looking for is patients with asthma with an asthma review in the last 12 months, including a self-management plan, same day as the review, asthma control test, same day or the month before, number of exacerbations, same day or the month before. And they're also looking at an assessment of inhaler technique, although they don't pull a code for this actually in the business rules, but they're still asking you to do that, and to do that as a face-to-face. The other indicator, the smoking status, is income protected. COPD domain, 3 here, the register income protected, and also the Dyspnea scale and a subsequent record of referral to pulmonary rehab has also been income protected. But the one that's still there for you to do is percentages of patients with COPD with a review in the last 12 months, including a record of number of exacerbations and an assessment of breathlessness using the MRC scale. All these codes will be in our templates. The QOF depression, the depression indicator, which was the one that you had the window really of doing depression reviews within a certain time frame, has been income protected. But as I said earlier, don't take your eye off the ball, because if it comes back next year, they do look back to January for this having been done. Also, if you look at the QOF guidance document produced by NHS England, they are highlighting the importance of patients with a new episode of depression being reviewed within 2 to 4 weeks to see whether treatment's working. And of course, patients starting antidepressants aged 18 to 25 years or thought to be at increased risk of suicide should be reviewed after 1 week. So they're still really saying do the reviews. With the QOF learning disability, the learning disabilities register income protected, but it's highlighted in the QOF guidance that GP practices are now required to have a process in place for recording that a patient requires reasonable adjustments, details of what those reasonable adjustments are, and whether the patient consents for the information to be added to the NHS spine. I'm flagging this up because at CEG we've done quite a lot of support for this. So there's a template out there so that you can record the reasonable adjustments. There's also a pop-up alert which you can see on this screen. There's one for EMIS, there is one for System 1, but the EMIS one just looks like that. So you'll see if somebody's got a reasonable adjustment recorded, you'll get a flag to indicate that. The QR code on that side, on the right hand side, is just because we've done an easy video tutorial on how to use the template and protocol and a little bit more explanation about the reasonable adjustments. Okay, just to highlight the QOF mental health domain. So mental health register income protected, and as I said at the beginning, one of the other indicators that's income protected in this domain is M8021, that was to do with patients receiving all 6 elements. However, you still have to do the individual elements. So you've got to do care plan, BP, BMI, alcohol, lipid and blood glucose. And as I said earlier, in some of the enhanced services, the mental health will have an indicator that a patient has received all 6 elements. So just because it's come out of QOF doesn't mean that it's not in your enhanced services. There's a number of PCAs that you can use for this, things like blood pressure declined, body weight measurement declined, etc. Cholesterol test declined. So if you put those in the patient's record, they will act as PCAs. Just another note about the invitation codes. So these are when you're inviting patients to come in for their reviews. The LTC invitation codes, just a reminder that if you have 2 invite codes recorded at least 7 days apart, that'll remove the patient from the eligible denominator, unless of course the patient does come in and you do all the work. You can use this overall invite code, which is the Quality and Outcomes Framework Quality Indicator Related Care Invitation. That will exclude patients across all the disease searches. So say, for example, if you had somebody who had heart failure, diabetes, CHD, and they weren't coming for any of those reviews, if you just use that indicator code, invitation code, that would remove them for all those domains. It's up to you. I mean, you can decide to just use the specific invite for each domain if you want to. Oh, and just to say that all the searches, the QOF clinical system searches, are, of course, you'll find them, they've been produced by EMIS and they're on System 1. So you'll find them in your GP contract folder for EMIS. So that, I'm sure you all know this actually, but they're there and you can have a little look to see how you're going.
Okay, so what I'm going to do is go through a few more QOF indicators and other services, including public health indicators. So that's where we're starting. So there are 7 public health indicators. There's 5 of them shown here. So starting off with patients aged 45 or over who have a record of blood pressure in the last 5 years. 15 points if you achieve 90% achievement. There's a simple register of patients with obesity age 18 or over. So this is a protected income indicator. And then there are three smoking indicators. So one is, I'm not going to read all the LTC, but one is with all LTCs with smoker status in the last 12 months. So that's 25 points for 90% achievement. And there's one for patients aged 15 or over with, obviously smoker with an offer of support and treatment in the last 12 months. And that's 12 points, 90% achievement. So that's the third smoking indicator. So again, patients with an LTC who have a offer of support and treatment in the last 12 months. So that's protected income indicator. So the last two are cervical screening indicators. So for women aged 25 to 49 who have had a cervical screen test in the last 3 years and 6 months. So 7 points for 80% achievement. And then for older women 50 to 64, cervical screening with a longer sort of date range, 5 years and 6 months. So you get 4 points for 80% achievement. Now, there can be 3 invitations. The first 2 invitations are sent national by the National Call Recall Service. However, for the third invitation, practices have a contractual requirement to send that one. So quality improvement domain, and again, this one is a protected income domain. It has 74 points, and I think it had about 6 different indicators. So on this one, just to highlight the guidance, that all practices are encouraged to recognize areas of care. So, you have to review those and, those ones that require improvement, and then obviously take appropriate steps to fix those. So again, for a QOF indicator, so this is the catch-up indicators for vaccinations and immunizations. You have 3 child immunizations. So the third ETAP dose given before 8 months, first MMR dose given age 12 to 18 months, and for children 1 to 5 years old with 2 MMR doses and ETAP IPV booster. Now each one of these indicators, you can earn 18 points for each one of those if you achieve 96% of vaccinations. And then the one for elderly people, so people reaching 80 years old in the last 12 months with a shingles vaccine that was given in the last 10 years, so basically when there was between 70 and 79. So again, this is one is a catch-up to try and achieve 60%, and for that achievement you would get 10 core points. Now the quick notes about the achievement on this catch-up for QOF vaccinations catch-up. 5.7% of NEL practices, that works out as 15 out of 262 got full points, so well done to those practices. Somebody needs music. So that's 15 out of 262 got full points. And then 25% of NEL practices, that's around about 65 practices, did not get any points at all. So clearly there's room for improvement. I just wanted to highlight to you that CEG does have quite good searches for that in our immunizations and vaccination folders. So as you can see on the screen, we've highlighted the EMIS ones, but there's also versions for System 1. We've also got a very good active patient learning childhood immunizations tool, and that one you would need to download, etc. But once you download it, and if you need training, you can always book training with us. But that tool, it allows you to filter specific vaccinations, so you could filter the the QOF catch-up vaccinations. You could filter on age. You could filter on patients due a vaccination next week, so you can plan for those and book those patients in. And you can also view patients who are overdue by 1 week, 3 weeks, or more than 4 weeks, etc. And there's all sorts of other filters that you can have, including contraindications or complex vaccination schedules, etc. So I think most practices are already using this tool. So, but if you're not, then give it a try. Just a word on seasonal influenza vaccination program. Payment and activity recording is now by CQRS. So just a quick reminder that practices need to have signed up with CQRS no later than the 31st of July. So if you haven't done that, so please go ahead. And I'm not going to read all the 9 cohorts, but they're on the screen. You get paid £10 and 6p for the administration of each influenza vaccination. Now, as you know, CEG provides searches on both systems, EMIS and System 1, for this to support you on this vaccination, schedules with recalls, etc., and activity. But we also do a dashboard that we publish every week. So there's the weight management enhanced service, and this is a fairly straightforward metric. So it's looking at patients on the obesity register with BMI in the last 4 months who have been offered a referral to weight management services, and we've listed some of those services there. So starting off with patients with hypertension and or diabetes. So that's the NHS digital weight management service. There are local authority funded tier 2 weight management services, and then third there's the NDPP service, and there's the NHS type 2 diabetes path to remission program, and that's a total diet replacement program. Now the payment tariff is £11.50 per referral per patient, and we know that there's a limit to referral allocation. Now, on both EMIS and System 1, we have sets of searches. You'll find them under your childhood immunization, your QOF folder. And what these do is they give you searches to identify cohorts of patients for referrals. There's also some data quality searches. So this is mostly focusing on referral codes that are not compliant with enhanced service. So if you do find any patients in those searches, you would have to locate the code when it was entered. Just use the check patient option, go to the consultation, and then edit that, replace that in the original consultation with the correct code. And also we have searches in there that will assist you with your CQRS submission. So moving on to PC and IIF changes, as you know, over the years, they started from about 15 indicators to 5 indicators last year, and now it's further reduced to just these 2 indicators. So the first indicator is just a QOF learning disabilities register, patients aged 14 and over, with an annual health check and a health action plan. That health action plan must be done on the health check date, so on the same appointment basically, or it can be done after that health check. For some reason, if it's done before, it won't be valid. So in addition to this, a recording of ethnicity is required, and as you know, ethnicity is EBA, so whenever it was recorded. So, but do check your searches, because if there are any health checks that are not qualifying, it might be because of the ethnicity. So it's something easy to fix. You can call the patients, send them flores or whatever, whichever way is best for you. Now there's a lower target and an upper target, 60 to 80%. And then the second indicator is for is a percentage of lower gastrointestinal 2-week weight cancer referrals, accompanied by a fit test result. Now that result has to be been done on the 28 days before leading up to the referral. So we think it's obviously to make sure that the referral is appropriate. So PCN DES. We do urge you to read the document because it has a lot more in it than just this. We've just highlighted a few areas, but there's a lot of other areas where you need to see what your practice needs to be doing on this. So for CVD prevention and diagnosis, there are two indicators. So to improve detection of hypertension, so obviously patients not on the hypertension register, but whose last BP is greater than or equal to 140/90 and appropriate follow-up for that. And then to identify and manage raised lipids. So this would be patients at risk of familial hypercholesterolemia. Also, there's early cancer diagnosis indicators to review your cancer referral practices and improve support of early diagnosis, and also to improve screening uptake. And then there's also structured medication reviews to your high-risk cohorts. And what does CEG provide to support you with this? We have searches and templates for care homes, IIF, structured medication reviews, and we have obviously CVD pages in the LTC template, etc. And coming soon, we have CVD searches are currently being worked on, and we hope that those, we plan for those to be published soon. Also, we have another tool, cancer diagnosis audit tool. That tool is to review practice processes around suspected cancer referrals, leading to confirmed diagnosis. So in pink, you can see there's the link. So when you get this presentation, you click on that link and you'll be able to request that tool and request training as needed. Or if you want to head it off, just contact your facilitator and they will send you the link for that. There's also dashboards that we've created for care homes, PCN DES, IIF, and SMRs, and cancer screening. So moving on, as you know, this PCNs are increasingly being commissioned to provide certain services, and they've got their own systems now. And so CEG has been working with PCNs to get them to sharing agreements, and this is mainly so that they can access the templates and documents, so we can publish those to them, and to facilitate their work. And of course, this is creating a nice and healthy dialogue between CEG and PCNs, so it's looking good for the future. And I think that's all for now. Are there any questions?
Jo's been answering a lot of them in the chat, but there's one that she hasn't answered so far, and it is, can we not use no consent for immunisations if we have tried to contact patients on several occasions?
For immunisations, generally you can code them, but immunisations tends to be an absolute thing, and they don't allow any sort of PCAs at all. So what you've vaccinated is what would be reported. That's it. It doesn't reduce. There's no way to reduce the eligibility, and no way to improve activity at all with PCAs. But you can code it, and it'd be good for future reference. And those are the sort of things that you might be able to identify using our APL childhood IMS tool. Does that answer your question?
Okay. Next question. Would you be able to talk us through the dashboard?
Which dashboard?
They haven't put.
Oh, well, dashboards we get. It looks like it's a general question, but yes, I mean, we can support practices on any of the dashboards that we publish, any of the searches, any of the products, the tools, etc. But you would have to book that individually. And if you have very specific requests, we can always cover those at CEG Tuesdays. I think the CG chooses are in City and Hackney, but in other localities they may be other days. But the regular support sessions, you can come along and ask questions like that, and then I'm sure we can go through any dashboards or searches that you require support on.
Okay, they've confirmed you answered the query on the no consent. And dear Lewis, for weight management DES in the inclusion criteria of obesity as well as diabetes or BP, as the CEG search seems to suggest this. Question.
Sorry, let me just.
Yeah.
Do you want me to come in on that, Lewis?
Yes, please, Joe. Yeah.
Okay, because that's Raj. The DES is to do with your obesity register. However, the reason why the CEG have split the searches into different kind of eligible cohorts really links to the type of services that those patients can be referred to, because there's slightly different searches, slightly different services for people with different conditions. So that's why that's been done that way.
Then we've got any suggestions on the smear list? What to do if we have called them multiple times but no response? Any codes available? Any way to achieve the target?
I thought there was a patient not responded to the 3 invites. I think that's acceptable.
And the question about the dashboards, it was regarding the dashboards that you mentioned in your slides, so IIF, SMRs, etc.
Yeah, well, those ones would be a bit more of an extensive thing because they're quite large.
We might not have time for that, would we, Lewis?
Yes,
not now.
We wouldn't have time, not today. But we'll make a note of that and see if we can provide training on those in future. But watch our bulletins, and we should be able to publicize anything that we decide on doing on that.
There's one more in the chat, but a couple of people have had their hands up. I'm hoping the mic situation is going to work now. No, I'm sorry. The 2 people with their hands up, can you please type into the chat, please? Because the mics are still not working, I'm afraid.
I think you can now unmute yourself if you've got your hand up.
So unmute yourselves, yeah.
So there was a question, can O2, when a GP doesn't want to give the fit test for referral as it might cause delay for the 2-week wait, it goes into the exclusions. Can we get codes for exclusions? Sorry, that moved here if possible.
No, they can't, can they, Mike? That was, I think, Mike, you know.
No, so yeah, so with regards to the lower GI 2-week waits, the only reason you wouldn't need to do a fit prior to referral is if it's an anal mass or ulceration. Everything else, they want you to do a fit test prior to the date of referral. If the patient declines a fit test, you could do the referral, but it will look to see, so if you then have a fit test kind of subsequently, it will look at that fit test and see that it's after the date of referral. So they are wanting a fit test before the date of referral. I think services are quite keen to have that because it helps them triage referrals as well and think about what investigations they want to do.
Okay, thanks, Mike.
Regarding to the invite, but even after 3 invites, the smear list is still the same, isn't it?
Even after 3 invites.
Yep. They still stay on the denominator.
There is the code though, Toyin's put that, you know, which I mentioned as well. There's no response to the 3 invitations. So I'm guessing that if you put that in, that should take them out actually. Okay.
Yep. We'll find out the answer for that and then publish it in the chat later on or on our bulletin.
Okay, then 3 invites for smear tests. Can these invites only be text message, or the last invite, should it be a letter?
No information on the type of invites. I imagine you can invite any way you can.
I think we might need to come back on that one. come back on that one.
Yeah.
Let me
we'll
see if I
come-
can find anything on that one while you're talking, Tracy. I'm slightly worried about the time, Tracy, because
Yeah, that's the last question, Jo.
is that the last question? Okay. Okay. I'll have a little look on that. It's me.
Right. Okay, so my colleague now will take over.
Okay, so I'm going to go through the new LIS that you have. It's the Data Accreditation Improvement and Incentive Scheme. You may know it as DALS, as that's what the abbreviation is. So you have two sections to this. You've got the phase 1, which is data accreditation, and then you have phase 2 and 3, which is the wider determinants of health. So we'll start with phase 1. So for phase 1, what you had to do was we sent a fact file and you had to change your consultation types and your job roles. Now, this is it's a very easy thing to do. It won't take very long. If you haven't done this already, the original deadline was the 31st of March 24, but it has now been extended and we will accept them all the way up till the end of the 31st of March 25. So in a typical practice within NEL, if you have around about 3,350 patients, for changing those two things, you can earn around £358. If you've got a practice around just over 6,000, you can earn just over £600. And if you have a larger practice around 11,000, then you can earn just over £1,000. So it's 10p per patient based on your registered list size. And that was of the 31st of March. Please do this. If you haven't done this already, we really encourage you to do this because this is very easy money for you to get. And I'll just show you what you need to do. So this is the EMIS screenshots, and from the fact file, you just need to adjust, if you haven't already, your job roles, which is the left screenshot, and your consultation types, which is the right screenshot. With the job roles, we're only looking at the active users. So please do get this across because we really want you to have the money for this, Liz. And then here's your system 1 screenshots. So your left one is your consultation types and your right one is the job roles. It does work slightly different with system 1. So what would happen is once you've made these two changes, your local facilitator would then need to verify this. So that would more than likely be you can jump on a Teams and then we can confirm by you just showing us these things that you've done exactly what you've been asked to, and then that's it. So that's for your phase 1. So please do, if you haven't already done this, then just take the 5, it wouldn't even take 5 minutes, the 5 minutes just to get this over and done with. And then as soon as we've received the screenshots, we can then put through for payment for you. And we will then send you an invoice, just depending on your list size. So moving on to the wider determinants. So this is the local incentive scheme, and is to improve the primary care data on wider determinants of health. And the aim of it is to address inequalities in the country's most disadvantaged regions, which NEL is classed as one of those. So what are we looking to do? So it's identifying a target cohort and agree the incentive, which has been done. Create a data set using SNOMED codes, so making sure that everyone is coding the same. Support the data captured in general practice, again, so making sure everyone's working in the same way and recording everything. We then provide training and we support as well around this. And then what it'll do, it'll then embed a routine within your practice. So moving forward, all the information that's required for these patients will then just become routine, and you will do this for all of the patients moving forward. Who is your cohort? So the cohort for the wider determinants part is anyone aged 16 and over, And then you have your two different groups. You have your new registrations since the 1st of October 2023, and then your target cohort, which is the most deprived areas in North East London. And the way that they have done that is based on the index of multiple deprivation, so the IMD score. So what do you need to do? So phase 2 has two parts. Part 1, you are required to achieve a minimum and also maintain 95% on ethnicity, language and communication. So this will be for all patients that are over 16. Doesn't matter whether they are within the two cohorts that I just said, it's everybody over the age of 16 must have ethnicity, language and communication needs recorded. And then once you've reached the minimum of 95%, you can then move on to part 2. So the part 2 is going to be a little bit trickier because of what you're asking the patients. You need to get a minimum and maintain 25% of having patient recorded for isolation, literacy and communication, housing and employment income vulnerability. So each individual one of those needs to be at 25%. Then once you have reached and maintained both of those, you can then move on to phase 3. So with phase 2, the payment will be made after April next year because the payment is until the 31st of March 2024. But if you do reach the minimums on those two, you can move on to phase 3 and be paid for phase 3 before you're paid for phase 2. And again, like I said, all that's required is the minimum of 95% has been maintained in your ethnicity, language and communication. And then your minimums on the other social isolation, literacy, communication, housing and employment and income vulnerability. And then what will happen is, again, you will send us screenshots of the searches just so we can confirm that you are at those minimums. And then we can then arrange a phase 3 visit for you. So that would require us either we can come into the practice or it can be done over Teams. And we just have a process that we need to go through, just check some things. And once we've done the visit and we've confirmed that you have passed phase 3, we will then send you an invoice straight away for you to claim for phase 3. One thing I do want to make very clear, if you haven't done phase 1, which was your job roles and communication, job roles and consultation types, if you haven't done that, you cannot move on and be paid for phase 2. You have to complete phase 1 before any payment will be made for phase 2. We do have a dashboard available for this, and this is online. If you don't have the login details to look at any of our dashboards on the website, then please do let your local facilitator know and we can give you the login details. And as you can see, this does them in the two different sections. So your purple section is your phase 2 part 1, so ethnicity, language and contact preference. And then the green is your phase 2 part 2, health literacy, housing vulnerability, income vulnerability and social isolation. So that's a very good dashboard to look at, and you can filter it like all of our other ones by going into your localities. Okay, so what resources and support are we giving to help you with this? As I said, we will do facilitated practice visits. So if you need help, you don't understand the searches, you're unclear of what templates to use, then please do contact your local facilitator and we can help you with that. We've provided searches so that you know who you need to contact. We also gave an Accurex flurry. So this was to help the phase 2 part 2 to make it easier for you, because you can send this Accurex out and it will automatically code the answers back into your systems, so you do not have to do it manually. We've provided the templates again, which is for capturing the information and also signposting if someone needs referring to a social prescriber, that's all within the template. And this is, the template is a standalone template called Wider Determinants of Health, but it is also available in all of our other templates as a page. So you can find that in any template that we have put out for you. We also gave a video that you could put up in your practice reception. And what this does was it just explains to the patient why you're going to be asking for these questions. So it is a very good thing to use just so that the patients are pre-warned before they may receive these text messages that some patients do deem are quite intrusive. So a little bit of information before you're going to send out the text message generally goes down well, because they know what or why you're asking for this information. We also provided you with a fact file, and that has all the information on it that you need. This is your data accreditation Bible, basically. It has all of the targets on there, it has the costs on there and how much you're going to be paid for each phase. It's got the links on there, it has all of the information that you have. Again, if you haven't received this, please do let your facilitator know and we can get this sent out to you. And we have done numerous webinars and local forums where we've presented to yourselves plus multidisciplinary teams so that everybody knows why this LIS is happening and also why you need to get this information. Okay, so I'm going to move on just to see what can us at CEG offer you. We offer you a large suite of templates, which again are really good, especially in each individual area. You have your local LTC review templates, which, as most of you are aware, is very good. It tailors to the patient that's in front of you and only brings up the pages that you need. We've got your adult immunisations, you've got a cancer referral and safety netting template, structured medication reviews, which is good for your pharmacist to use when they're doing their medication reviews. You've also got your local NHS health checks for each borough. And then also we've got women's health templates. A lot of these templates are good for all clinicians, so your nurses and your doctors can use all of these. But also what I do want to bring up is in every area you all have an F12 key, and we all have a CEG template launcher. So if you're unaware of this, again, please let your facilitator know. We can send it to you. It is an individual user setup, but if you set up the CEG template launcher, it will give you every single template that we offer, all in the one place. So the one click and then every template's there. Even if you didn't know what templates we provided, set that up and that will show you exactly what templates we've got. We've also got a very large suite of documents for you, which includes, you've got your referral forms, so your 2-week waits for your suspected cancer, you've got asthma stop smoking, you've got various care plans as well, just to name a few, the adult asthma, your child care plans, you have SMI care plans, and then also just other general documents, air pollution toolkit. Again, you've got the wider determinants of health questionnaire that's available to you as well. And then you've got your searches. We've got both your EMIS and System 1. They are set up very alike. So you just need to go into your practice support searches 24/25 in EMIS. And then in System 1, they are under your CEG local area, and then you'll see you've got your 1 to 8 in there. So again, they're very good to use, especially your local incentive schemes, because that will tell you exactly what you're doing and what you need to do as well. And then, as Lewis mentioned earlier, we have our dashboards available. So you have NEL-wide dashboards, which includes cancer screening, care homes, IIF, just to name a few. But then you also have your locality-based ones as well. If you don't have the login details, let us know and we can send them to you. And depending what scheme it is, they will either be weekly, monthly or quarterly. just depending. But you can find them all on our website and you'll be able to see how you're doing. Then we've got our weekly bulletin that gets sent out on a Monday. So this is just to encourage you that if you're not signed up to receive these, then please let us know and we can get you added onto the mailing list, because any changes that we make will be, you will be advised through this. So please do look at this. We do provide information normally to say that we've updated our templates or our searches, but then it's not just about CEG information as well. We do provide other information on there. We advise you about information through QOF, any changes, etc. We'd just like you to be up to date. So please do look at them if you receive them. If not, let us know and we would get them sent to you. And then we've got our fantastic APL tools. So at the moment, we've currently got our childhood IMS tool, which again is very good for your nurses and hopefully will make their life a lot easier if they use this, as well as the admin team. They can do a tag team and work with it together. And you've got your cancer diagnosis audit tool. You've got your APL NDPP tool, so your National Diabetes Prevention Programme, which obviously there is a les around that one. And then we've got our AF tool as well. So when we send these links out, the pink is highlighted, so you can click on that. You can also contact your local facilitator and we can send you the link. You have to register for these tools, and that's just because if they do get updated, and you have requested it before, then you will automatically be sent the updated version. Okay, so what makes us at CEG unique? This is, we do your practice visits and one-to-one support, depending what you require. These can be in person or virtual, whatever suits you better is absolutely fine by us. You can contact us by email and by phone, again, whichever is easiest for you. And then each individual area holds their regular CED drop-in sessions. It could be weekly, bi-weekly or monthly. And with these, again, we encourage you to attend these because we have an agenda in most of them, but we also like to hear your feedback. So if you come to one and you feel like we didn't cover something that you would like to know about, then let us know and we can always factor that into the following drop-in sessions. And it's also a good place for you to speak to other practices as well. Maybe they might not be within your PCN, they might be somewhere else. So it's a good place to come and mix with other practices that you might not talk to normally, and you could help each other out. You might know the answer to something that another practice needs answering that we may not know the answer to. So please do try and come to those because they are a very good thing to attend. And then, so we have our webinars. So on here, you've got the QR code down there on the right hand side, and that will take you to our website. We've got the website link up there. We have got the dashboard link here, but like I said, you will need login details. So you can click on here, but unfortunately you won't be able to get in unless you've got the login details on there. And then lastly, just to show you who your local practice support teams are within your areas. For a second. And again, you've got a QR code here on the right hand side, so you can scan that and that will take you to the same thing, just located on our website.
Did
anyone have any questions?
Tracy, there was a question on, I mean, there's stuff about people wanting to be added to the mailing list, which is fantastic because we can do that. So we'll absolutely do that. There was something about the video, which I can't quite see. Oh, can we put this video on practice website too? I guess that's the video. Is that the wider determinants video? Or
yes, yes, it is.
So yeah,
yes,
okay.
Yes. So it will be a link. So yep, you can add it onto your website as well.
And then there's something about if you don't have access to the CG dashboards, please get in contact with us because we can give you the login details.
Yes.
I'm conscious that we have overrun by about 6 minutes. I don't know if anybody's got any other questions actually just before we go. I think there was a lot of questions, which is great, about the kind of like the invite codes and some of the PCAs. And I think rather than getting ourselves into a bit of a muddle about all of this, as I said, I think it'd be quite useful for CG to do a fact file about this. So we will look into doing that and then send that out to you so everybody is super clear.